next video. Today we're going to be looking at life as an orthopaedic SHO. It can be anxiety provoking stepping up to being an SHO, especially if you've just done your F1. And therefore we're going to look at a few key tips, tricks and rules that you can follow to ensure that you can get the most out of your orthopaedic placement, as well as managing patients safely. So let's look at rule number 1. Reg Contact. Whether you're working in a tertiary centre and therefore have a registrar on call with you for orthopaedics, or working in a district general hospital where you may be going around to see orthopaedic referrals by yourself, where your registrar is in the operating theatre, it's important to know that you do have support with you on call. And so the first thing I would do at the start of the day is ensure I have the contact details for the registrar who is on call with me. This ensures that if you have any queries or any questions, you can quickly run this by your registrar. And it also ensures that you can check in with your registrar every 2 to 3 hours to inform them of what's been going on and whether there are any other patients that need to be seen. Not only will the registrar appreciate this, but it will help you to feel supported knowing that you have someone to contact. The second point is organisation. This is key in any job role in medicine, and especially in orthopaedics. You may be very busy, and therefore at the beginning of the day, I'd recommend getting a sheet that I would divide into different sections for the patients seen in different environments, such as patients referred from the emergency department, patients seen as trauma calls, patients referred from the ward, and so on. This will help you to put patients in the correct areas and ensure you don't miss anyone. It's also crucial to make sure that if you are discharging anyone, to get their contact details in case the plan needs to be changed or they need any further information given to them once it's been discussed with a senior or at the trauma meeting. You should, however, always endeavour to discuss patients you are going to discharge with your registrar until you feel comfortable to discharge them by yourself. Moving on to the next point, resources. In particular, post guidelines, ortho bullets, and so on. Orthopaedics is a vast topic, and as an orthopaedic SHO, there's a lot of material out there to help you learn about the key pathologies and presentations you may be dealing with. In particular, the British Orthopaedic Association Standards for Trauma, or the BOAST guidelines, are readily available on the internet by just typing them into Google. These go through the key presentations you may come across on call, such as ankle fractures, hip fractures, and gives you standards as to how to manage the patient. Ortho Bullets is also useful for a quick idea and guidance on almost any orthopaedic condition. And there's a wide range of other resources, such as this YouTube channel. Moving on. Managing patients can be tricky, especially if you're new to it. And there are a few key frameworks and guidelines that I would use. Have a feel free to look at the 4 R's video that I've done on my YouTube channel. And this will give you a useful framework about managing almost any patient presenting to you. Very briefly, this looks at the 4 R's of management, including resuscitation, reduction, retention of reduction, and rehabilitation. This ensures that injuries are dealt with in a systematic manner, with the most urgent injuries being treated first. Point 5 looks at the orthopaedic history, and in particular focusing on the mechanism, the past medical history, the drug history, and the function of the patient. Whilst you all know how to take your history, these are the 4 key things that need to be taken in almost any orthopaedic history, as they give crucial information. For example, the mechanism will tell us whether this is a high or a low energy injury, and therefore our index of suspicion for any further injuries that we may need to look for. For example, a patient in a high-speed road traffic collision is likely to have more injuries than that who's fallen over from standing. The next point looks at past medical history. This is crucial for patients undergoing an operative intervention and even those who are being treated without an operation who may need these optimised to improve their outcome. For example, cardio or respiratory issues may need to be optimised before a patient can go for an operation or be given a general anaesthetic, and therefore an anaesthetic review or medical input may be necessary. The next point looks at the drug history, and this can impact not only the operation but also its chances of success, where the patient needs to be done on the operating list, and the prognosis going forward. For example, patients who have blood thinners or who take these regularly will have a greater risk of bleeding during the operation, and therefore these should be appropriately managed as per your local guidelines. It may also be appropriate to consider whether blood products will be required for these types of patients. Other things include patients who are type 1 diabetic and therefore may be on insulin may need to be done earlier in the operating list, and patients who take medications such as steroids may need to have these changed to an intravenous form, or increasing their risk of infection going forward. So the last point looks at the function, and this is crucial as this gives us an idea of the patient's baseline and therefore how realistic it is at what we're trying to achieve and whether they'll be able to return back to that. Moving on to the next point. If the patient can't walk / mobilise, then admit. Patients may not be able to mobilise for a variety of reasons, such as if they have a bony injury in their lower limb, or even when they don't, they may struggle to. Therefore, it's unsafe to discharge these patients home, as they would not be able to correctly mobilise and get about. Now, if the patient does not have an acute bony injury, or it is not an orthopaedic issue, it may be more appropriate for them to be admitted under a different team. However, if they have an orthopaedic issue such as a hip fracture, they are going to need admission and management of this. Moving on to our next point. So if an open injury or neurovascular deficit, admit. It's often anxiety provoking as a SHO knowing which patients can be admitted and which can be discharged safely. You should discuss this with your registrar before discharging any patients until comfortable to do so. However, some key rules are if the patient has an open injury, and that means if they have a wound overlying a fracture, this patient needs to be admitted due to the risk of infection and therefore they need expedient treatment. Patients who have any neurovascular deficit in their affected limb also need to be admitted as a rule of thumb. The neurovascular deficit may be due to a number of reasons, but this should be monitored and the patient may need further management such as an operation. For a better idea about how to assess neurovascular deficit, see my upper limb neurovascular and lower limb neurovascular assessment videos. Moving on to the next point. Do not do anything if you're not comfortable with it. As an orthopaedic SHO, you'll be asked to do many activities and see many patients. It's absolutely acceptable and appropriate to say that you're not comfortable with doing an activity if you've not done it before, or if you feel that it is something you do not have the knowledge to perform. However, you should then seek your registrar or senior to help you with the activity, or try and seek the team that is going to most appropriately be able to manage the patient. The key principle is, however, you should not be forced or feel pressured to doing anything if you're unable to. The next point is to involve medical teams early. In orthopaedics, there are many patients who are old, frail, and have multiple comorbidities. And even if the patients are being admitted under the orthopaedic team, it may be useful and actually crucial for them to have medical input for optimization preoperatively for patients who are going operations such as hip fractures, or for patients who may need medical management, even if they're not being operated on, to ensure that they have a good outcome, as these premorbid conditions can compound any injuries the patient may have. And finally, the last point is to focus on patients who are getting ready for theatres need a few things doing for them, considering of their nil by mouth status and when they need to be nil by mouth from, consenting and marking, VTE assessment, and optimization. Any patients undergoing an operation need to have these things considered. When they need to be nil by mouth from, they need to be consented and marked, and this may not be appropriate to be done by yourself, but you should ensure that this is done by someone appropriate who knows about the operation they're having and has either done or has a good enough knowledge to be able to perform that operation. The VTE status is crucial, especially in patients with lower limb injuries. Therefore, venous thromboembolisms are crucial to be considered and may need to be started on a low-dose anticoagulant such as heparin, which is done in some trusts to reduce the risk. And finally, optimization, which links back into getting other teams involved to optimize the patient before surgery. And finally, the last thing I'd say is to enjoy the orthopaedic placement. It's a fantastic specialty with a lot of opportunity for learning, and whether you want to be a general practitioner in your future career, or a medic, or a surgeon in a different specialty, orthopaedics has key skills that you can learn to help you, such as a wide variety of presentations you may see in general practice, or being able to aspirate a knee joint, which may be useful if you're a medic and you're presented with a painful knee in a patient, or whether you're managing patients who have multiple systems that are injured and may have orthopedic injuries. I hope that was useful. This is by no means supposed to be comprehensive, but I hope this gives you more of a flavour of some of the rules to follow and how you can ensure that you get the most out of your orthopaedic placement while managing patients safely. You should of course supplement this with your local inductions and conversations about what happens in your local hospital or trust, but this will give you a good overview. Thanks for watching. Please feel free to leave any messages or comments in the comment section below, and I'll see you on the next video. Thank you.